So hi everybody, welcome to the Finals Crash Course Theory session on Obs and Gynae. Tonight we've got Elisa who will be going through the presentation with us. Please stop us and ask any questions. We'll be watching the chat. Just pop your hands up or ask your question there and we can answer those. I'll hand over to you, Elisa, now.
Thanks, Ellie. So my name's Elisa. I'm a GP trainee at the moment. Just a little bit about me, and probably hopefully why I've been asked to give you this talk is I have a bit of an interest in obs and gynae, so I thought I wanted to do it and ended up doing a year in a tertiary centre. I realised the surgery wasn't for me, but still love the medicine. Sat my DRCOG last year and then ended up doing 6 more months in obs and gynae during my GP training. So hopefully I have some knowledge to impart, but yes, like Ellie said, please definitely ask questions as you go along, and hopefully I can answer your questions. I'm trying to make this hopefully as interactive as possible using SVAs to kind of go off. I definitely have not covered everything because there is so much within this whole subject. But I've used a couple of things. So I tend to use nice CKS summaries because that's where I'm doing a lot of my learning from at the moment, but recognise that maybe as a medical student, that might not be your source of learning. I tended to also use patient.co.uk and Geeky Medics because that's what I used to use as a student and PassMed as well. And my pictures are all from DermNet. So hopefully we'll start with an easy one. Ellie, I might need you to kind of shout out some of the answers you're getting because I assume people will not. I mean, I don't mind if people want to shout out answers or if they want to put them in the chat.
Yeah, that's fine. I can shout out from the chat.
I'm hoping this is an easy one for you guys.
Oh yeah, we've already got.
Yeah. Oh yeah, perfect. I can see them coming through actually, to be fair. Yeah. Cool. I'm going to move on very quickly on this one because I'm hoping that you would have all said C as well. So just a quick whistle-stop tour about antenatal care. So your first trimester is weeks 1 to 12, second is 13 to 28, and third is 28 to 40. And in that you could also add your postpartum, which is your birth to 6 weeks. So just a little bit about antenatal care. So usually women would book around 8 to 12 weeks, ideally under 10, and within that booking a few weeks you would expect they would get some bloods done, so an FBC, a group and safe, so we get their RESA status, things about hemoglobinopathy, so thalassemia and things like that, and then your infectious things like hepatitis B, syphilis and HIV, and all women get offered a urine culture as well to look for asymptomatic bacteriuria. Women would then get their first scan between 10 and 13 plus 6 weeks. You would want to confirm your number of pregnancies. Hopefully you've got a viable pregnancy there, and then you know what you're dealing with in that pregnancy. Women would then be offered a trisomy screening between 11 and 13 plus 6 weeks, and then you get your anomaly scan between 18 and 20 plus 5 weeks. When you're seeing women, you would expect that you would measure their symphysis fundal height, and at 20 weeks onwards, you would expect that it would match the gestational age plus or minus 2 weeks. So if they're 24 weeks, you'd expect they'd measure between 22 and 26 centimeters. And you would expect that women feel their babies to move around 16 and 24 weeks. If it's their first pregnancy, maybe a little later, so around 20 weeks, and you tell them that if they don't feel their baby movements by 24 weeks, then they should tell their midwife. In terms of down screening and trisomy screening, so usually we do the combined test, and that includes the nuchal translucency, which you'll get in your booking scan, beta HCG and a PAP-A, and essentially the risk is more likely if you have a high HCG, a low PAP-A, or a thicker nuchal translucency. And within that period, we also test for Edwards, which is trisomy 18, and Patau's, which is trisomy 13. If women book late, they might be offered the triple or quadruple test, and those are the blood tests which I put in there. So we'll move on to another question now. So you are working in A&E. I've tried to make these as kind of F1E, F2 type situations as possible. So you're an F1 in A&E, a woman who's 9 weeks pregnant presents to you with nausea and vomiting. She's afebrile, but she looks quite dehydrated, and you do a urine dip which shows 3+ ketones. She's lost some weight, and you do some bloods because she looks dehydrated. Her sodium's a little bit deranged, and you ask her about any travel because she's turned up with nausea and vomiting, which she's travelled 3 months ago. What do we think is the most likely diagnosis here?
Getting lots of E's coming through.
Ooh. Yeah, so I put hyperemesis. I guess in your medical school finals, you get asked as an SPA, what's the most likely diagnosis? Because you would get a range of things that would be possibly likely, and then some which are hopefully less likely. So in her, you could say that she just has nausea and vomiting in pregnancy. She could very well have a UTI, which can cause dehydration and feeling unwell and sometimes vomiting in some people. Infectious gastroenteritis would also be one of your differentials, and hopefully DAK could be there, but should be lower on the list. So as we all know, nausea and vomiting in pregnancy is extremely common. Usually it begins between the 4th and the 7th week of pregnancy. Usually that will peak by week 16 and then hopefully should start to trail off by week 20. If you get nausea and vomiting that starts after the 11th week, you might want to think that actually this is probably not related to pregnancy and think about other things. On the more extreme spectrum of that, some women do develop hyperemesis gravidarum, which kind of was very big in the news in the last few years. So I've just seen that question. I'll come back to that in 1 second. I shall come to it now. So ketones wise, so ketones you can get when you're dehydrated or if you haven't eaten. So that's why I kind of threw the DK in there a little bit just as a red herring. So if anyone presents as dehydrated or not eating, you can get raised ketones, even though raised ketones might make you think about DK, for example. And that's why in this woman, you would probably do your full set of bloods, including a blood gas, which should give you your blood sugar as well, just to make sure you're not missing something that might be a bit of a curveball. Does that hopefully make sense, your answer? In terms of diagnosing hyperemesis, you would want the definition is basically prolonged, persistent, severe nausea and vomiting that's not related to any other cause. You would get some weight loss, so we say at least 5%. So this woman, her booking weight was 50 and she'd lost 3 kilograms, so that's more than 5%. And you would expect to see electrolyte imbalance because they're so dehydrated. Ketones used to be a very big thing in the diagnosis and management of nausea and vomiting in pregnancy. So when I first did my obs and gynae placement, that was a few years ago now, we wouldn't discharge anyone, for example, who had ketones of 3+, because that was part of the criteria. It's actually not longer any part of the criteria, but it gives you an idea about their clinical hydration status. So that's why I put it in there still. In terms of assessing the severity, we use a score called the Puke score, and that looks at, for example, how many times they've been vomiting in the day, how many times they've been retching, and how many times they've been feeling sick. And we actually use that score in practice to decide, are we going to maybe give this one a little bit of hydration and then send her home, or are we going to keep her in and do something different? And what you would not like to do is make sure you rule out other causes, which is why you would do your bloods and do your urine dip and things like that. In terms of risk factors for hyperemesis gravidarum, it can often be a sign of a molar pregnancy or twin pregnancy. So often the thinking is that having a higher HCG level, which is what you get in those two differentials, can cause the more severe nausea and vomiting rather than just being kind of normal nausea and vomiting in pregnancy. So that's why we often do an early ultrasound scan on women who present with nausea and vomiting in pregnancy. In terms of complications, like you said, we can get weight loss, dehydration, electrolyte imbalance, and AKI. And because women can't keep up their nutrition, they often get deficiency of B12 and thiamine, which can then, on the very, very extreme end of it, lead to venous encephalopathy. And also being so dehydrated and being pregnant can increase your risk of having a VTE, a venous thromboembolism. So, for example, when we admit women with hyperemesis or severe nausea and vomiting, part of the protocol in hospital is to give them low molecular heparin because they're at higher risk. In terms of management, depending on what you're going to do with that woman, often we see women with nausea and vomiting and pregnancy in GP, for example. You can give them simple advice, so rest as needed, avoid triggers, so heat, odours, noise, try simple foods like plain biscuits, crackers, eating smaller and often or maybe cold meals, drinking little rather than often, and sometimes things like ginger or acupressure, so there's bands that you get when you've got travel sickness, for example. In terms of medication, you can use cyclizine or prochlorperazine as your first line. go on to another question now about antenatal care. So you're an F1 or F2 maternity triage. A woman who turns up, she's 32 weeks pregnant and she's got severe itching of the palms of her hands and the soles of her feet. She tells you it started a week ago. She's tried some emollient creams because she's got a background of eczema, but the itching has kept her up at night, and she's not sure what to do. What would you do next? Yeah, perfect. I'm seeing lots of Ds. So again, SBAs are kind of designed to have some right answers in there and some more right answers and some very wrong answers. So my answer was also doing bloods. You probably would do some of the other things on that list. You would probably advise it to take some antihistamines. Depending on the rash, you might give her a steroid cream, or again, depending on the diagnosis, which I think a lot of you are trying to rule out here with your answer, you may well go on to start her on ursodeoxycholic acid. So I'm assuming a lot of you thought or wanted to rule out obstetric holistasis, and that's probably the most important diagnosis to rule out. So basically, it's a condition where you get impaired bile flow. The etiology is actually not quite well known, but we know that it could present from 20 weeks onwards, and like we described in the case, you get itching of your palms and your feet, and it's usually worse at night. And you diagnose it by doing bloods, basically, like you've all said. So you would expect to get raised bile acids, and you might also get raised elevated liver function. And what I've put in brackets there is that, for example, if you were to see this in GP, or if a midwife were to see this, this would be a same-day referral to maternity triage, because it comes with risks when you have OC. And the reason I put pregnancy reference ranges is because the reference ranges for LFTs and pregnancies are slightly different, but hopefully that should not come up in your medical school finals. I think that would be a little bit mean. So you would do your bloods, and then if you recognize actually this lady's got raised bile acids, you would then want to first monitor the fetal well-being. So usually what happens is, in practice, is women turn up to maternity triage, we examine them, we examine where the rash is or what the itching is or where it is. We ask her about fetal well-being, so fetal movements, and we would often put them on a CTG monitor to check how the baby's doing. And the reason we do that is because OC is associated with an increased risk of stillbirth and premature delivery, which are basically two outcomes that we definitely don't want. And depending on the protocol of the hospital, you would either, or her gestation, you would either do bloods weekly and then decide maybe to deliver her a little bit early, or you would then do them 2 weekly, but that would depend on the protocol of the hospital that you're working at the time. In terms of treatment at the time, because having that itch is not very comfortable, for some women we give them a menthol aqueous cream, so that menthol kind of takes that the itch kind of as a distraction from the itch. You can advise them to take antihistamines, so usually we go for a sedating one at night because then it allows them to sleep as well, so something like chlorphenamine. And in some women, they go on to have ursodeoxycholic acid, which is a treatment for the raised bile acids. And essentially, once you deliver, your LFT should get better. If they don't, or when you're monitoring these women and you find that actually the LFTs are going up, then you would need to think about a different diagnosis for why you've got a raised bile acids and bilirubin. So the menthol, it's like having mint. So you know when you have gum in your mouth, you get that cool sensation. It's like a distraction from the actual itch rather than a treatment for the itch. Just thinking about other rashes and itching in pregnancy, because women do turn up to triage and then you think this doesn't quite fit, so I'm just going to talk you through a couple more rashes. So OC doesn't actually present with a rash, it can present with excoriations because women are itching so much, but the other conditions I'm going to talk about do present with a rash. So one of the most common ones that women turn up with is a condition that we call Pups. So that's polymorphic eruption of pregnancy, or pruritic urticarial papules and plaques of pregnancy. It usually presents later in pregnancy, so in the 3rd trimester, and it presents with itchy urticarial papules that then coalesce into these kind of bigger plaques that you can see on this picture. It usually starts on the abdomen, and usually notice that it happens in the stretch marks around where the belly is getting stretched. And often one of the common signs of Pups that differentiates it from other rashes is that you usually get umbilical sparing. So On this one, hopefully you can see at the bottom of the belly button, it's actually not on the belly button itself. And this we would normally manage with emollients. Sometimes you might give them a topical corticosteroid cream or antihistamines as well to help with the itching. And then there's 2 more rashes which I wanted to chat to you about. So another rash which women have can be atopic eruption of pregnancy, more common in the first trimester, and it's more likely in women who have a history of eczema. And you basically get eczematous lesions which affect your typical atopic site, so your flex areas where women would normally expect to get their eczema, for example, and you would treat that just like you would your eczema, so emollients, anti-itching agents, and then sometimes some topical corticosteroids as well. And then the last rash which I had on my list, which we always consider when women come in, is pemphigoid gestationis. It's actually quite a rare condition and occurs later in pregnancy, but it's an erythematous urticarial papular and plaque type rash on the abdomen. And this one actually usually is in the umbilical region, which you can see is different from the Pups type rash. And then it often goes on to form these tense blisters like you would usually get in pemphigus. And this would be a referral to dermatology, and they would often treat with topical or systemic steroids and then things to also help with the itching as well. So another common thing which usually presents in obs and gynae is blood pressure. We're kind of hot on blood pressure. So have a read of this one. You're in clinic, woman is pregnant for the first time. She's been seen by her midwife. Her midwife recognized that she's got a background of hypertension normally, which she takes ramipril for, and then she asks you, the doctor, to see her. What would you advise her best? Seeing lots of C's. Would anyone try anything different, do you think? Yeah. Yeah, I've got good variety on this one. Okay, this one's quite interesting because it's very specific. There's 2 answers which would kind of contend for being probably the right thing to do, or hopefully the right thing to do. So I went with this one. Some people might have said E, actually, which technically is also right, but I'll hopefully explain over the next few slides why C was my SBA best answer. So in terms of ramipril, you would actually stop that in pregnant women because ramipril can have an effect on the fetal renal system. So definitely don't want them taking ramipril, and you wouldn't wait until the 12 weeks, you would switch it immediately. And actually, as I was writing this question, I looked at the NICE guidelines and realized that as a GP, I could stop it. I didn't even realize that myself. I thought I would have to refer, but there's guidance that GPs can actually tell women to stop taking it because you obviously don't want to affect the fetus's renal system. And then the reason why I say E could have also been correct is because when we're thinking about hypertension, preeclampsia risk, which is what we tend to think about with high blood pressure in pregnant women, you would often start women on aspirin at 12 weeks to prevent them from getting preeclampsia. So we'll talk a little bit about that in a second. The other option, which actually wasn't given to you, could have been to stop her blood pressure medication completely. So if you look at the NICE guidelines, if she presented to you with a blood pressure of 110/70, or she was symptomatic from her hypertension, then actually you could warrant not giving her any medication and seeing how she goes, because she'll get her blood pressure checked very often every time she presents to her midwife or antenatal clinic. You could argue that methyl dopa was at one time kind of a medication of choice, but I think we've tended to move away from that, so I'll talk a little bit about that as well. So physiologically, blood pressure falls in the first trimester until 20 to 24 weeks, and then it usually comes back slowly up to pre-pregnancy levels. So in pregnancy, normally your cardiac output increases because there's increased demand from the placental circulation that's growing. And then to increase the cardiac output, your heart rate increases slightly, so normal would be 70 to 90. And then to increase your cardiac output as well, you would increase your stroke volume, so your pump volume. And then during the second trimester, blood pressure usually drops, even though the cardiac output is going up, but because the placental circulation is expanding and the systemic vascular resistance decreases, your pipes open up and that drops your blood pressure. So when you see any pregnant woman, you'd be expected definitely to do a blood pressure and do a urine dip. And if you get a blood pressure of a systolic that's 140 and above or 90 and above, you would definitely expect to refer them straight away to be seen by maternity triage or someone the same day from the Obs and Gynae team. Thinking about how we classify blood pressure in pregnancy, so our lady had pre-existing hypertension, so she had known high blood pressure even before she got pregnant. So we would classify her as having pre-existing hypertension. So anyone who's got a blood pressure of 100 over 140 over 90 before their 20 weeks, but they have no protein in their urine and no edema, we would classify them as having pre-existing hypertension. Then you have your next level, which is your pregnancy-induced hypertension. So these are women who never had blood pressure problems before, and then they kind of hit 20 weeks, and then you see them in clinic and they've got a blood pressure of over 140 over 90. At this stage, you would definitely dip their urine because you'd want to check if they've got any protein in their urine, and you'd make sure they have no edema. If they haven't got those two things, you still wouldn't classify that they've got preeclampsia, but you would say that they have pregnancy-induced hypertension. And you would expect that that would actually get better as soon as they give birth as well, because the system goes back to what it should be doing. But they are at risk of having preeclampsia again in the next pregnancy or having hypertension later in life. And then your preeclampsia would be diagnosed as having high blood pressure, protein in your urine, and then you may also get other symptoms, which we'll talk about as well, but you would want to see your triad of high blood pressure, protein in urine, and edema as well. In terms of, because I can't remember if I explained it quite properly, but in terms of coming back to the aspirin, when you see women in clinic, you would look through their risk factors for having preeclampsia. So one high risk factor would be having pre-existing high blood pressure, and you would start those women on aspirin at 20 weeks. So just talking a little bit more about preeclampsia, and I haven't gone into too much detail because I can see that on the Instagram account there's a really good vignette about preeclampsia, and I know that they're going to release the answer after this talk. That it's actually got a lot more than I've talked about on there, so have a look at that this evening. It's a really nice explanation. So like we said, preeclampsia is your triad of new hypertension, proteinuria, and edema. And it's thought to result from abnormal placenta. So the removal, so once you remove your abnormal placenta, your blood pressure gets better, your preeclampsia gets better. So during pregnancy, the placenta becomes more vascularized, and that allows for exchange of water, gases, solutes between mum and baby. But if you get abnormal development of your placenta, it can lead to poor placental diffusion, and that is what is thought to cause preeclampsia. Again, preeclampsia, like obstetric cholestasis, the etiology of it isn't actually quite well known, and I know that it's being researched at the moment still. If you do develop preeclampsia, we know that there can be other complications that come from that. So you may end up getting renal insufficiency. So that's why we do a whole list of bloods when we are considering that you might have preeclampsia. So you might, if you see a creatinine above 90, we're worried that that would actually be classified as probably having deranged renal function for women. You might see a deranged liver function, usually ALT might be deranged. You would get abnormal neurology, which I'll come to in a second. You might get deranged hematology, and then like we talked about, your dysfunction of your placental circulation, which essentially puts baby at risk as well, and that's why we worry about it a lot. In terms of your neurology, women might present with headaches, visual disturbance. They might say they've got some pain in the epigastric area or the right upper quadrant. When you examine them, things that you would definitely look for, you would check their reflexes. They tend to be hyperreflexive. They may have signs of clonus, and that you may see swelling in their legs or their hands or their feet. In extremis, some women actually might present having a complete seizure, and that is what you would call eclampsia, and that eclampsia is basically having a seizure in pregnancy due to the process of preeclampsia. We talked a little bit about prevention and management. Like we said, first line would be labetalol, and if they can't take labetalol, for example, they've got asthma, then your next line would be nifedipine. If they have a blood pressure of 160/90, we would actually admit that lady to monitor her and potentially deliver her, depending on what gestation she is, or what symptoms she's coming with. And basically, like we said, delivery is secure. And then if you look at the answer from the Instagram questions tonight, there's a little bit more about how we prep baby and things like that. So I know that's in there as well. So coming to delivery, you are again in maternity triage. You see a woman who presents to you at 40 weeks. Her waters have broken. She's having regular contractions. She's going into labour. This is her second pregnancy, and you see from her file that she's had Group B strep in the past. What would you advise her to do during her labour? Yeah, lots of C's. And the reason I say advise is because actually a few weeks ago I'd seen a woman who refused antibiotics, and that's because lots of countries do lots of different things. So absolutely, you can advise, but you can't make someone do something. Oh, I saw a different suggestion there. Yeah, so some women, when they rupture their membranes early, and the reason I put erythromycin was a bit of a red herring, you're right. We actually use erythromycin if they have a penicillin allergy, or if there's prolonged rupture of membrane. That's a little bit second line, so hopefully you wouldn't be quizzed on that in your exams. Some women, like I said, refuse to have antibiotics, and that's fine, that's their choice. And what you would normally do when babies are born to women who have GBS, especially if they've not been given a good course of antibiotics or no antibiotics, is that you would monitor that baby for about 12 hours to make sure they don't then develop signs of sepsis. So hopefully another little easy one, but woman goes into postpartum hemorrhage. What is your most common cause? I'm liking all the variety. Yeah, so I think I saw mostly B, which is what I would go for. And usually, oh, I've not got my notes on here, but there's a really good article on Geeky Medics, which I was reading today, about postpartum hemorrhage. So uterine atony is the cause of postpartum hemorrhage in about 80% of women who have postpartum hemorrhage. So postpartum hemorrhage would be defined as 500 milliliters or more, and then you go into a major, which would be above 800 or 1 liter, depending on which hospital you're in. And then you can actually then classify your postpartum hemorrhage into primary or secondary. So primary would be women who have just given birth and they are bleeding a lot. So uterine atony is your most common cause, and then you would go for things like your vaginal tears or coagulopathy, and retained placenta as well. And you would figure that out by basically doing your management. So if a woman is bleeding, the first thing you would do is kind of press down on the uterus to give some uterine pressure to help contract the uterus. And then you would start giving some uterotonic agents to help, again, clamp down the uterus. But if you're finding that actually it's not stopping bleeding, you would also at the same time hopefully be examining. You might see a large tear, which you'd hopefully repair. Or you would do an internal examination, and you might end up seeing that the placenta itself isn't looking whole. There could be a bit missing, and that's what you'd be worried about. Or you might be able to feel a little bit, and because that placenta would still be attached to blood vessels, it would be bleeding. The reason I put endometritis in there is because endometritis and retained placenta can actually be causes of secondary postpartum hemorrhage. So these are women who have given birth, they've been fine, and they represent with very heavy bleeding. So your endometritis is basically infection of the womb. It's an open cavity, and that's why you've got lots of bugs and bacteria there, and there's a risk that you could end up getting an infection in your uterus. So what we find is that women go home and then they represent to maternity triage a couple of days later, and they say, actually, my bleeding's got much worse, or you know, I'm not feeling well, or you know, things like that. And one of your considerations when women turn up with heavier bleeding than when they went home with could be either that there's still placenta there, which you would maybe do a scan for and see, or that they've got an infection in the uterus, and that's again causing some more bleeding. So we've given birth. We're going to talk a little bit about afterbirth. So woman presents to her GP. She's had a baby 5 days ago. She's feeling anxious, always a bit tearful, not sleeping well. This is her first pregnancy. She's married and she has good support at home, and she's got no previous mental health history. What would you suggest that she might have? Yeah, I'm thinking a lot of it. That's what I would go for. Again, it would depend on what you had in front of you and the history of who you were looking after. So let's talk a little bit about, we'll talk about postpartum and then we'll come back to the mental health side of things. So postpartum period is from birth to 6 weeks afterwards. And physiologically, you'd expect that your cardiovascular system returns back to normal because the additional load from the extra volume starts to diminish. The uterus after you give birth would usually be at 20 weeks, so that would be at your umbilicus. Then hopefully over the next 12 days, you would expect that it would reduce down to the point where you probably feel it just above the pubic bone at about 12 days. You would expect that one would get lochia. So initially it'd be quite fresh red blood for the first 3 to 4 days, and then slowly it would become more reddish, brownish, and then stop eventually. A couple of common problems which may present back to you postpartum that we worry about or we don't want to miss. I'll go through those, but there's a nice poster which some of you might have seen from the RCOG, which is called the 3 Ps, and that looks at kind of, it's an A4 sheet and looks at the most common postpartum complications and most common causes of postpartum maternal death. So things that are quite common are mastitis. So you may see women who come in with enlarged, engorged, red, painful breasts. They may have fever, feeling unwell. Depending on how they present, if you think they're septic, you would send them into hospital. Or if you think you can treat them in the community, you might give them flucloxacillin as first line. And you would explain to them that they should continue to express all the breast milk to help the tissue kind of clear out, basically. We talked a little bit about secondary bleeding, so I'm going to skip over that one. One of the big ones that we definitely don't want to miss is puerperal pyrexia, or basically maternal sepsis. So between 2016 to 2018, 31 women in the UK died from sepsis. So it's quite a big thing in terms of maternal death that we talk about. And usually the cause is from bacteria that live in the genital tract. You would hopefully not want to miss that. So if you saw a woman who was febrile, tachycardic, tachypneic, septic, you would get her into hospital extremely quickly, and you would do a sepsis 6 as you normally would do. The other thing that we worry about is VTE, so venous thromboembolism. So as we all know, pregnancy increases your risk of having a clot. 1 in 1,000 pregnancies end up having a VTE episode. And pregnancy gives you 4 to 5 times more risk than non-pregnant women. And actually the postpartum period, which people often forget about because people have had their baby, is actually the period where there's the highest risk. So we say there's a 20-fold increased risk in women who are postpartum. So when women leave hospital, they must have a risk assessment done to say, to look at their risks. And if they have a certain number of risks, they will be sent home with low molecular weight heparin, for example. And then the other thing that we think about women who have given birth when they leave hospital is their contraception as well, because from day 10 to 1 you can start becoming pregnant again. But I'm not going to go into that too much for now. Thinking about maternal health, so the way that we can assess maternal health is using the Edinburgh postnatal depression screen. So sort of classify into baby blues, postnatal depression, and psychosis. I've just seen a question. That is a good question. I've only ever seen DOACs given when we have then subsequently either, that's a good question. No, actually, no. What I was thinking about was women who have developed a clot very late in pregnancy. They tend to actually go home on treatment dose low molecular weight heparin. I'm actually not sure about the breastfeeding risk, but I'm fairly sure off the top of my head. I can have a look on the BNF.
I'm just looking at the BNF now. Rivaroxaban, for example, is avoiding breastfeeding.
Yeah, I can't think of anyone that I've sent home with a DOAC. That's a good question. Definitely not warfarin. And I suppose it would also depend on if they're planning to breastfeed. That's one thing. Some women don't want to jab themselves every day. So I guess that's a good question, because what I would do is I would often send them home with low molecular weight heparin, and then refer them on to a hematology clinic if they were diagnosed with a clot. If they're not, depending on their risk, if they're medium risk, they get 10 days of low molecular weight heparin or prophylactic dose. Or if they are very high risk, they get 6 weeks. Just for a question there about the 3 Ps. I can't remember what the 3 Ps are, but there's a really good leaflet which I am going to send the link for, and then you can have a look on that, because it gives you, usually talks about the 3 causes of maternal death. I think every couple of years the RCOG make a new leaflet. Is that okay? Sorry, I haven't seen it for a little while. Coming back to maternal mental health. So when women are known to have, so there's a huge drive on, that's okay. There's a huge drive on looking after sort of maternal mental health and domestic abuse at the moment. So anyone that you see in clinic, that you are asked to check in on them, basically. And we know that women who have a history of mental health are followed up by special mental health midwives. That's during their pregnancy and also after, because they do have a higher risk of having depression and sometimes psychosis as well. It's very common for women who, especially women who had their first baby, who may not have a lot of support to develop what we call baby blues. So about 60 to 70% of women develop baby blues. It's usually seen in the first few days of kind of giving birth, going home, adjusting to this completely new thing that's happening in your life. And is that the 3 Ps? Sorry, I'm looking at the chat as we go along. And basically you would give them reassurance. Hopefully a health visitor should also be supporting them as well. And as a GP, you would keep an eye, and you would, hopefully they should get better, but if not, you should be able to recognize that and give them the support. Around 10% of women, that's a good question. I'm actually not sure in terms of how quickly it tends to resolve. And I suppose that's what your 6-week check would be for, because at that point you would also check to see how they were doing. And by 6 weeks, that's when we kind of start getting into the territory of probably prolonged, we wouldn't call that baby blues. It's usually much shorter lived than that. It's just a kind of a readjustment phase rather than depression, is what I would say. So when you get a question, for example, to say the woman has been fine, but actually 4 weeks has gone by, or you see her at a 6-week checkup and she's very tearful, she feels like she's not a good mother, or partner comes in and says, I'm a bit concerned, then that's when you start to think, if you're doing medical final questions, for example, actually this is a bit too late for baby blues to present, and it's a bit too long for baby blues to present. So that's when you probably be thinking about your depression. Does that hopefully help, I think, with the answer? So it's a bit more prolonged than you would expect it to be, and it would start later than what you would expect it to start for baby blues. And these are the women that you kind of would treat as if they had depression. So you would offer your CBT or cognitive behavioral therapy. Having a baby at 3 months, you're still extremely busy. So some women will say, actually, no, I can't really commit to doing CBT. But you would also, at the same time, consider offering them an SSRI, so an antidepressant. First line in women, we tend to go for acetylcholine or paroxetine. They are secreted in breast milk, but they're thought not to be harmful, and paroxetine tends to not go into breast milk as much as what the thinking is from the BNF when I had a look last. The thing that we don't want to miss alongside depression is psychosis. So it's quite a rare thing, but you need to keep an eye out for it. And that's women who have had a background of mental health problems before, particularly schizophrenia, are kept looked after by special mental health midwives. So the onset of psychosis would often be around 2 to 3 weeks. In an exam question, it tends to be partner presents to you very concerned about his wife who is not bonding with baby, who is concerned that someone is trying to hurt their baby, those type of things that you know, or hallucinating and things like that. That's the sort of vignette that you would get in an exam question from what I can remember, or the ones that I've done for when I sat the DRCOG exam. So you would tend to get in psychosis, like you would expect, severe mood swings and disordered perceptions, so your hallucinations. These women need to be admitted urgently into a mother and baby unit to be looked after. And we know that once that's happened in one pregnancy, they're kept a close eye on because there's a high risk of reoccurrence in future pregnancies. Ellie, was there anything else in the chat at all?
No, I can't see anything else now.
Sure. So moving on to a little bit of gynae. So a 49-year-old presents to you, you're in GP, and she tells you that she's been having some hot flushes, feeling a bit anxious. She's actually missed her last 2 periods the last 2 months, and she's worried she's going into menopause. She'd like a test for this. What would you advise her? I think a mixture of A's and B's, yep. And again, because this is an SBA, I think some of these are probably things that you might do yeah, that's definitely a thought. Pregnancy, possibly. Exactly. So these are things that could all have a potential to be correct. So I ended up picking B, and I will explain to you why in the next slide. So FSH, a raised FSH, so over 30, indicates ovarian failure. So that's why, that's the test that we were all thinking about, absolutely. And let's talk a little bit about why she wouldn't need an FSH. Oh, we're not going to talk about menstrual cycle. So diagnosing menopause. So menopause is essentially a retrospective diagnosis. So it's a diagnosis that you can make when a woman has basically not had periods for the last 12 months and she's not using any contraception. So there's nothing that would stop her from having periods, for example. You can diagnose this lady with perimenopause because she's above 45, she's got symptoms of menopause, and she's getting irregular periods. And basically diagnosing perimenopause and menopause are clinical diagnoses. You can think about having an FSH if a woman is between 40 and 45 and she's got menopausal symptoms. Or if you're considering a premature ovarian failure. So these women who present to you under the age of 40, they've got menopausal symptoms. Nothing else is explaining why else they're feeling the symptoms they have. And then you would measure 2 FSH levels 4 to 6 weeks apart. And if they're above 30, then you can diagnose premature ovarian failure. So in her, unfortunately, she doesn't quite warrant a test because she doesn't hit that middle period of 40 to 45. But you might think about starting her an HRT, and depending on what she tells you about her red flags, you might think about an ultrasound scan. And if you're not winning with her symptoms, you actually might end up referring her to gynae. So yeah, all plausible things. So thinking a little bit more about menstrual abnormalities. So one of the things that we worry about that women can present to you is having irregular periods. And when women present with irregular periods, we worry that they could have PCOS. So that's polycystic ovarian syndrome. So these women tend to present with a triad of having oligomenorrhea, so not having a period every month, so every kind of 35 days, or they may get no periods. They have excess androgen levels, and on a scan you may see polycystic ovaries. You don't actually need to have polycystic ovaries on a scan to diagnose PCOS, but they may end up presenting to you with symptoms of hirsutism, so male pattern or kind of heavy hair growth, weight gain, oily skin, acne, and then irregular periods as well. And they are increased risk of developing type 2 diabetes and having raised cholesterol. In terms of managing these women, it would really depend on what their symptoms were, what was bothering them the most, and what they were thinking about doing in terms of childbearing or not. So that's why I haven't quite put management down there, but you would give them pain management advice, or you may think about, if they wanted to have a period, you could think about inducing a period with hormonal treatment. If they were worried about acne or hirsutism, you could then give them an anti-androgenic contraceptive pill, so something like Dianet, which has, I can never pronounce this, but cypriandinol, which can kind of help reduce those androgen levels. So another question. 29-year-old presents to you with painful periods. She gets regular periods. They occur every 28 days, but kind of a few years after she began having periods, they started becoming increasingly painful, and she's noticed that when she has sex, it's quite painful as well. Yeah, seeing lots of B's. Yeah. Yeah, perfect. So I would have gone with B as well. Having said that, you've got a couple of different things which could be making you think the other ones. So dyspareunia can be a symptom of having PID or an ovarian cyst, but you think maybe that might be a little bit more one-sided when you examine her, for example. But it's the cyclical thing, I suppose, which makes you think about endometriosis. So let's talk a little, oh no, yeah, let's talk a little bit. Or if not, okay. I'll come back to endometriosis, but if you were diagnosing her as having endometriosis, what's our gold standard investigation going to be? Yeah. And the question I have for you next on that is, I'm sure you all know getting a laparoscopy is not going to be something that's going to happen next week. So you may end up doing a transvaginal ultrasound, referring her for an ultrasound scan. And if that ultrasound were to show a bulky myometrium, what else? I haven't given you options, but as a bonus question, what else might you think? Yeah, absolutely. Because adenomyosis is a similar concept to endometriosis, where you get your cyclical pain, but you may also get heavy bleeding, but again, you get your cyclical element to it as well, absolutely. So endometriosis is growth of endometrial tissue outside the uterine cavity. So that can be on the ovaries, uterosacral ligaments, pouch of Douglas, the rectum, sigmoid colon, bladder. You can also get deposits that are outside the pelvis, so on the lungs, for example, or the diaphragm, which is much, much more rarer. It's a hormone-mediated process, and it's associated with menstruation. So as your hormones change during the menstrual cycle, it can cause bleeding of that tissue. You get chronic inflammation and then scar tissue development as well. It's estimated that 1 in 10 women have it, but you get varying degrees of a presentation and diagnosis, and therefore diagnosis. And like we said, the gold standard would be laparoscopic exploration. Because it's so insidious and so variable, it can take on average women 7.5 years to be diagnosed with it. And essentially it can cause women chronic pelvic pain, infertility because of the adhesions, and depending on where those adhesions are, sometimes even bowel obstruction. And like I said, we'd expect it to be cyclical because it comes with the period. Because of the fact that you have that kind of that's a tricky one. The reason why I actually didn't end up putting adenomyosis in my initial question options is because I would also expect with adenomyosis, because it's a bulky myometrium, for her to have heavy menstrual bleeding as well. That's slightly one of the differentiating factors, but in reality, probably not, and that's why you would end up getting your scan, if that makes any sense. But the heaviness might be the differentiating factor for you. In terms of chronic pelvic pain, pelvic pain would be a pain that's there for 6 months or more. And we talked about having dyspareunia as well. Management, again, would depend on her symptoms, the extent of the disease, and what she wishes to do. So looking at the NICE guidelines, they suggest that you can consider analgesia, so paracetamol and NSAID, so thinking about mefenamic acid. You would offer women a hormonal treatment, so for example, a combined oral contraceptive pill or a progesterone pill, or maybe even the Mirena, and explain that hormonal treatment can reduce the pain related to it, because you're basically stopping that hormonal cycle which you have with a period, and shouldn't have any permanent negative effects on fertility. Obviously, if she's trying to conceive, then you wouldn't start her on a hormonal pill. You would refer her to a fertility specialist. And if you're having difficulty with treating it with your first line management of what you've tried in the hormone side of things, then that would be a point where you would refer on to gynae as well to give you some more advice. So thinking about menorrhagia, so you have a 38-year-old woman who presents to you feeling tired all the time, and as you normally would in GP, you'd probably do a blood test, which shows you that she's mildly anemic, and you ask a little bit more about her period. So she has prolonged heavy periods, and then you decide to feel her abdomen, and you feel an enlarged mass in her pelvis. It's firm, non-tender, not that painful. Yeah, absolutely. You would think that that's the most likely cause, I hope. Thinking about abdominal masses, yes, you could probably get a cyst if it was very, very large, possibly one-sided. You definitely want to think about ruling out cancer if you feel a mass in the abdomen. Pregnancy would hopefully be the most wrong answer, because she's telling you she's getting periods, but you've got a mass in her pelvis, who knows? And sometimes pelvic inflammatory disease can give you kind of abnormal bleeding as well. So thinking of, oh no, what have I done? Thinking about fibroids. So fibroids are basically benign tumors. They're a mix of smooth muscle cells and fibroblasts, and they form round, hard growths on the myometrium. And the peak incidence of them occurring is in women in their 40s. But they can happen at any point from when you start getting your periods. Usually a high incidence in Afro-Caribbean women as well. It's been found when I was reading on the NICE-CKS. And usually they shrink after menopause because they're hormone dependent. And often women tend to present with heavy menstrual bleeding, and that's when you tend to find fibroids. So complications can be heavy menstrual bleeding. If the mass is really large, you can get compression of the pelvic organs, pelvic pain. In pregnancy, you can also get fibroid degeneration as well. You would examine the women, so like we talked about, you would do an abdominal exam. You may feel a firm, enlarged, irregularly shaped, kind of a non-tender uterus, for example, a bulky uterus. You would expect that the mass itself can be moved, so it's not a fixed mass. And then you would, in this woman, you would definitely do a transvaginal ultrasound or an abdominal ultrasound. And NICE also recommends doing a blood test, an FBC, to make sure that they're not anemic, like our women in the case had. Management, again, would depend on what you find. So sometimes the hormone kind of, you might want to think about treating the heavy menstrual bleeding. So your first line for menorrhagia would be a Mirena, but you may not want to put Mirena there because the uterus might be so distorted from having such a large fibroid. They may want to actually think about having a family, so they may need to be referred to have the fibroid removed. It would completely depend on the symptoms. Some women may not want Mirena, so they may want things like tranexamic acid and mefenamic acid for the bleeding. So you're in glam clinic now. a woman presents to you with clear watery discharge. She initially thought it was thrush because she has some itching, but that didn't help, and has now noticed slight discharge. And then you're in gum clinic, so you take some swabs and send it off to the lab, and it shows some clue cells. Yeah, a little bit of a mixture, but I'm seeing lots of Bs. Yes, so this one probably wouldn't be an SBA because you've got your clue cells, which should be your clue for having bacterial vaginosis. So bacterial vaginosis isn't actually a sexually transmitted infection, but it is an infection that is basically an overgrowth of the normal flora in the vagina. Usually Gardnerella is the one that we find the most, and it can cause watery discharge, sometimes itching, and sometimes having a smell to it. The treatment for that would normally be metronidazole. So talking a little bit about pelvic inflammatory disease. So it's basically an infection of the upper genital tract. The infection spreads upwards from the endocervix, causing inflammation in any or part of the pelvis. Common causes, as we probably all know, are chlamydia, gonorrhea, sometimes mycoplasma as well. And you would get things like pelvic pain, infertility. Usually the tubes can become blocked. It's a risk factor for having an ectopic pregnancy, and sometimes women will present to you unwell with fevers, abnormal discharge, and you find that they've actually got a tubo-ovarian abscess. Sometimes signs and symptoms can be abnormal discharge, having dyspareunia, abnormal vaginal bleeding, and sometimes having secondary dysmenorrhea. So they've not had painful periods before, but suddenly they start having very painful periods. So these women you would examine. So you would do an abdominal examination where you might find tenderness, and then you would do your PV exam as well. You might find some adnexal tenderness or cervical motion tenderness or uterine tenderness as well when you do your bimanual examination. You're right. BV doesn't tend to, but sometimes you're right. It's a bit of a red herring. Sometimes people can present with itching with BV because they've got discharge and they've been itching, and it's kind of but you're right. That tends to be your thrush clue. So that was a bit of a mean question, actually. Hopefully that's yeah. And then women might say that they have got some abnormal discharge, which has got a colour to it or a smell to it. We'd be worried about sepsis if they present with fevers, for example. Often, even when I've seen these women in gynae clinic, I would still ask them to present to gum, because gum tends to have they tend to have access to kind of tie it all up into a nice package and then do contact tracing as well, which is what you'd need to do, and gynae tends not to have that facility. And then first line, according to the British Sexual Health and HIV Association, would be ceftriaxone, doxycycline, and metronidazole, but it would depend on allergies and what you're dealing with. So if you only find chlamydia or gonorrhea, then you would just go ahead and treat that, for example. But if you think you've got PID, you wouldn't actually delay treatment. You would treat them and then wait for your swabs to come back and then tailor that treatment. So I think we're on the final stretch now. Just a little bit about Gynecology and Screening. So 56-year-old woman presents to you with postmenopausal bleeding. She's been a little bit bloated, having some early satiety. What would you do next? Yeah, getting some variety. I actually changed this question, but I think I've uploaded the wrong presentation, so I'm going to go with what I've got on here. I think we got a lot of A's and D's, didn't we? Yes. So in an exam setting where they ask for the SBA, because I've done this when I've practiced exam questions and I've clicked CA125 or I've clicked something else, and then I found I've got it wrong. Which is a bit frustrating because these are probably all things that you might do for this lady, looking at her symptoms. But I went with the 2-week wait appointment because that would be the most appropriate next thing. She's got postmenopausal bleeding. She's 56 years old. You would probably refer her immediately and then do other things like ordering a scan and doing some blood tests. Yeah, you can see my altered options. I thought that one of them wasn't a good idea. But I think for an exam, the next appropriate thing as an SBA, single best answer would be 2-8, because that would be the thing that would be the most pressing. And then in clinic, they would do those things anyway. But you're right, probably would do all of those things, and maybe apart from a routine gynae appointment. So thinking a little bit about gynaecology before we wrap things up. Cervical screening is offered to all women in the UK who are aged 25 to 64. And it's actually moved to a HPV first testing now, rather than what it used to be in the past. So they would look at the sample, and if it tests negative for HPV, women will go back into normal recall. So you're 3 years or you're 5 years, depending on how old you are. If you're found to be positive, they would then look at the cells. If the cytology is abnormal, you will get referred to colposcopy for samples to be taken via LETS procedure. Or if the cytology is normal, you would just repeat your smear again in 12 months. And then you would take it from there, depending on the results. In terms of cervical, oh yeah, let me go back to that. The reason I ended up changing my fecal protected is because, or why I chose B12 and folate as part of one of my options, because she's a 56-year-old woman who's fatigued. So it wouldn't be, thinking in GP hat, it wouldn't be unreasonable to do some bloods to think about fatigue and anemia. So I thought B12 and folate might be a little bit of a red herring for some people, and that's why I put it in there as one of my options. Thinking about your cervical cancer, so women can present with postcoital bleeding, intermenstrual bleeding, and post-menstrual bleeding, and sometimes they present with abnormal vaginal discharge. Risk factors, as we probably all know, would be HPV 16, 18, and 33. If you smoke, if you've got HIV, and then I suppose the last two are in there because if you're having, I suppose the psychology is that if you're having multiple sexual partners or early forth intercourse, you may not use protection and therefore get HPV. But personally, I think that might be a little bit outdated. In terms of your endometrial cancer, it's basically cancer of the lining of the womb. The most common symptom that people present with is abnormal vaginal bleeding, especially post-menopausal bleeding. And that's why, and essentially NICE guidelines say that if you've got a 55-year-old woman who presents to you with postmenopausal bleeding, she must be referred under 208 to Gynecology clinic. And that's why for that option, she's 56, and that's why I ended up choosing D as my SBA answer. In terms of risk factors for developing endometrial cancer, so basically, if you've had too much estrogen, because estrogen affects the lining of the womb. So if you've never been pregnant, which stops your periods, if you have lots of period cycles, so early menarche and late menopause, or you get unopposed estrogen from HRT, or you have obesity, those could be risk factors. You would refer that to 2-week wait, but in terms of what they would do a transvaginal ultrasound and look for the endometrial thickness. If it's above 4 millimeters, it's abnormal, and that would then require a hysteroscopy and a biopsy. And then depending on the extent of what you find, you may then end up getting a hysterectomy or something further than that. And then lastly, we've got ovarian cancer. So ovarian cancer is a little bit more insidious in terms of symptoms. So women present with abdominal pain, weight loss, fatigue, loss of appetite, IBS symptoms, which is kind of a red herring because you tend to get diagnosed with ovarian cancer a little bit later in life, and developing IBS in later in life is a little bit unusual. And again, you would refer these women under 2-week wait, but you would probably also do with these symptoms a CA125 and an ultrasound as well to visualize the ovaries and see what's going on. And then definitive diagnosis and management would be a biopsy, and then management and secondary care as well. Okay, everyone, that's the end of my Obs and Gynae finals presentation. Thank you so much for listening. Just to go through, the references I used were mostly clinical with some nice CKS. Patient.co.uk is a favourite of mine as well. I remember using Geeky Medics as well and PassMed, like I said, for my revision, and that's what I've used in some of my slides. And just to be specific, the tables are from Past Medicine, and the pictures are all from DermNet as well. Thank you all for attending.